Welcome back to the channel, guys. Today we are standing on the precipice of a monumental shift in healthcare technology. If you've been following artificial intelligence space, you know that the pace of innovation over the past few years has been nothing short of staggering. But recent developments in what I'm going to call the real-time native multimodal AI are fundamentally different from anything we've seen. Now, we've seen a lot of changes, and we're no longer talking about chatbots. We're not talking about typing prompts into text boxes, waiting for the server to process it, and then reading medical summaries and stuff like that. No, we're talking about artificial intelligence that can see, that can hear, that can speak, and most importantly, it can reason. All right, it can reason and it can do all that in real time. So we're talking about models that can natively process physical world interactions like speech that we're speaking, me and you, and do that much more like human clinician does. So today we're going to do a deep dive into what native multimodal AI is, how it works, and what exactly is currently going on, and how to rewrite the rules for modern medicine. We'll explore the groundbreaking clinical applications, the profound ethic risk, and what this means for the future of patient care and for medicine. So if you're a physician, you're a medical researcher, or you're an investor in healthcare, or you're just someone who loves health-related matters and is touching to AI, this is a conversation you want to be part of, right? And this episode is particularly, especially for you. All right, so you cannot afford to miss this. So let's us begin by breaking down the technology itself. Before we continue, if you're meeting me for the very first time, my name is Dr. G. You can go ahead and, I want to meet you again the next time so we can have good understanding of what's happening to healthcare and in the world of AI. So let's begin by breaking down the technology itself again. So to understand why native multimodal AI is such a massive leap forward, we need to look at how previously the generations of AI has been able to manage data and how they functioned. Now, until recently, most advanced AI systems, including even the most powerful language models, basically work the same way, right? Primarily, they were text-based. By text-based, if you wanted AI to analyze anything, let's even say it's my voice I'm speaking right now, let's say it's a medical consultation interpretation, I must firsthand pass the audio through a speech-to-text. The speech-to-text model will get a text out and feed that into the language model. The language model will read the text and generate a text-based response, which was then pushed through a text-to-speech engine, which will now speak and I can hear it, or maybe just read it if I want to. Now, this is basically a disjointed pipeline, as seamless as you think it is, right? And because of that, it created a lot of latency, often several seconds of lag, which might be real depending on your internet speed as well, or if you're running locally depending on your system capacity. Now, putting all that together, there is this fluid of human conversation that was missing with AI interaction because of the wait time in between. So, furthermore, during the translation from audio to text, right, a massive amount of data was always lost. The text transcript does not capture the patient's tone, the voice, their gasping, or the breath, or that sense of urgency in their speech for healthcare, or their emotional state as well. It's not being captured. So, native multimodal AI completely eliminated this pipeline. However, this new architecture we have now are trained, from ground on text, on audio, and on visual data simultaneously. They do not need to convert your voice. That conversation I'm having with a patient from voice to text, they do not need to do that. They process the raw audio waveform directly. They do not feed on external program to describe what the image is, try to understand what this is about. No, they can see through the pixels natively alongside the text and the audio. This leads to two massive breakthroughs. One, first and foremost, is the near zero latency and profound contextual awareness. Near zero, it means as you're saying it, as they are seeing it, they're able to provide an output instantly. So we're talking about an AI that can respond in milliseconds, seamlessly interrupting and being interrupted, just like human conversations can be. Now, the good thing about this is that it can look through a camera, it can see the patient's physical presentation, it can listen to their cough, it can hear their voice, it can go through their medical history, and it can reason across all those details in the model instantly. How powerful can that be? So now let us transition that and see what that actually means for healthcare and for clinical practice. Now, because the implications of this are Very, very staggering, I must say, very staggering. So the first and most immediate, first immediate implication of this is what? Is the perfection of ambient clinical intelligence. By ambient clinical intelligence, I mean a presence that is with you while you're doing that. Now, in clinical care, one of the things we've known about is burnout as one of the greatest crises that is facing global healthcare practice, right? Now, and it's driven largely by a massive amount of electronic health record documentation that doctors and care providers have to deal with. Typically, every single day, doctors are going to spend hours every night acting as if they are data entry clerks. Currently, AI is able to help them as a form of AI scribe, but of course, they often are limited by audio processing only because they still require human corrections to the inputs and the typing. Even the dictations can, especially for those of us that have accents, everything is designed to function, let's say with the American accent. So if you don't have the accent, you literally will do better off not using those things than using it. However, multimodal AI changes everything. Imagine a small camera and a microphone array in the examination room. I know you have questions. I'll come back to that later. So a patient walks in with a limp. The AI sees the altered gait. The patient sits down, looking pale and sweating. The AI notes the diaphoresis, and AI is able to see the pallor. The doctor and the patient are having a conversation completely natural, right? The AI is able to hear the tone of pain in the patient's voice. When the doctor palpates the abdomen, instantly the AI is also able to hear that. Instantly, silent, the AI is synthesizing the visual, the physical exam findings, the auditory cues, and the spoken medical history into flawless, highly detailed clinical notes, right? It can simultaneously pull up the patient's past labs from the monitor without a doctor having to turn to do that. Very interesting. The doctor doesn't have to touch a keyboard. This restores the doctor-patient relationship. The screen that, created a digital wall between the healer and the patient has finally been removed, totally removed. Now, the second major application is in live surgical assistance and the procedural monitoring in the operating room. Imagine this. The operating room, as we know it, is a highly complex, dynamic, and high-stake environment. Currently, AI in surgery is relatively doing so little, right? It's largely just relegated to either the pre-planning or the post-op planning, or basically everything about planning. That is where AI comes in right now. But the multimodal AI can be active, real-time participant in the operating room. Now, by integrating the laparoscopic or the robotic cameras, the AI can continually monitor the surgical fields. Because, remember, it has the capacity to process videos natively in real time. So it can track the surgeon's instrument, it can identify the critical anatomical structures, and, as it's looking through that, like the common bile ducts or maybe the bladder, the ureters, it can see all those things, maybe just even the blood vessels, right? And it can provide real-time augmented reality overlays. If the surgeon, for any reason, mistakenly, his instrument is getting too close to a critical nerve, the AI can, of course, issue a verbal warning. Don't go there. Don't go there. All right. So furthermore, the AI can listen to the communication among the surgical team and everybody in the theater discussing the patient, right? It can track the timeline of the operation. It can monitor the anesthetic readouts. It can predict the potential of a complication long before it happens, at least minutes before it happens, right? So it is the ultimate surgical co-pilot. It's that kind of a companion you want to have with you in the theater, right? Because it's able to process the whole combined textbook knowledge of every surgery ever done before. It has the knowledge in real time, right? It's operating at the speed of light. And let's move on to the third application of this possible multimodal AI we're looking at today. Is the advanced telemedicine and triage. Of course, where Docerian comes in with our project. Right? Given that telehealth has exploded a lot, especially in the Western world and with the pandemic of COVID now, but it has always been limited by the physician's inability to conduct a proper physical examinations. A lot of people have questioned, do you want to see me over the phone? I want to see me over video. How sure are you're able to assess people effectively? However, multimodal AI is bridging that gap. Right? So, typical example is when a patient initiates a telehealth call, right? The AI can instantly analyze the video feed to assess their respiratory rate by watching their chest rise And 4, it can analyze their skin tone for signs of cyanosis or for jaundice or for any bruise, for any physical signs that can be seen by looking at the patient. All right. So given that, that is a big boost. It can listen to acoustic signatures of their cough to determine, is it a dry cough? Is it a wet cough? Is this cough croupy? All right. By asking the patient questions in real time, the AI can perform an incredibly robust initial triage, categorizing severity of the patient's condition and ensuring that when the human doctor finally joins the call, all right, they already have a comprehensive multimodal differential diagnosis for this doctor ready for review. That's because at this time, the AI has been able to take input from the visual, has been able to take input from what the conversation he's been having, and has access to patient history and has access to the current reality if available, and is able to make available to the physician on arrival a complete multimodal differential diagnosis ready for review. That's going to cut down significantly amount of time spent in doctor's consultation. So we also have to discuss the affective computing and the mental health. Now look at it. Psychiatry and neurology basically rely heavily on subtle clinical signs, micro expressions, psychomotor or retardations, speech latency, and let's even say flat effect, right? So because the native multimodal models that we're talking about now, they're able to process raw audio and videos. They can detect these microscopic nuances that even a trained human eyes might miss. So the AI can track a patient's vocal biomarkers over time. It can detect the earliest signs of cognitive decline in Alzheimer's disease and many of them based on slight changes. Something as simple as word choices and speech pacing. In treating depression, the AI can also objectively measure improvements in the patient's facial expressions, expressivity, and as well as their vocal tone over a period of time, or let's say over weeks. Right? Given that it's providing a quantifiable data in fields that have historically relied a lot on subjective assessment. And as you know, because they are subjective, so many patients, you pass them through the same doctor, they will have different readings from when you pass them through another physician. Of course, we're trying to take that away and provide value, reliable data right now. However, as medical professionals, maybe technologists, whatever you fall into this category, we must approach this shift with our eyes wide open. And I'm going to tell you why we do that. If you've asked questions earlier when I talked about cameras and audio in consulting rooms, maybe this is the answer you're looking for, right? Yeah, so the fact is that the integration of real-time multimodal AI into healthcare carries immense risk. The ethical dilemmas and limitations that we must rigorously address. The most glaring concern is patient privacy and data security. Now, we're talking about putting always-on cameras and microphones in the most intimate, in the most private spaces of human existence, the clinical exam room. Now, the emergency bay, the psychiatric office. Now, how do we ensure strict HIPAA compliance when massive amount of raw data are being fed into a multimodal system? All right, and the multimodal system is processing this data. First and foremost, the data cannot simply be sent to a public cloud servers without extreme encryption. That's first and foremost, first step. Now, it must have some form of encryption. It must have extreme anonymization. And most importantly, there must be stringent access controls to this data. If an AI system is hacked, the breach is no longer just text-based lab results, or personal identifiers as we see them today. It is raw data of videos of physical examinations and audio of deeply personal confessions of these patients. Invariably, we need to have a new system whereby patient consent must be radically reimagined. Because furthermore, we must confront the issues of AI hallucination as well, even if these other ones were not a problem, right? Because hallucinations will be high staked in a healthcare environment. Right, is real-time scenarios. Large language models, have been known to hallucinate. They fabricate a lot. In fact, you want to add that to a prompt as a way to tell them, do not provide me any detail that is not in the source material if you do not want them to hallucinate. Otherwise, a lot of time when something is missing, they just close the gap by generating information. All right, so now when this happens in text prompt, a doctor has time to read, recognize the error, and correct it. But in real-time multimodal environments, the speed of interaction becomes a liability. If an AI surgical assistant hallucinates and incorrectly identifies a blood vessel, and the surgeon, maybe he has not looked into this, or maybe he's not well acquainted with this, acting quickly cuts. The consequences are immediately fatal. This brings us directly to the quagmire of medical liability. I mean, that's the big monster in medical practice, right? When an ambient AI makes a mistake, who is legally responsible? Who becomes responsible when an AI that is supposed to provide guidance makes a mistake? Is it a physician who relied on the AI? Is it a hospital that procured the system? Or is it a technology company that provided or developed the model? So invariably, what this means is that the legal frameworks currently governing medical practice are entirely unequipped for this kind of issues, right? So, and therefore, they need to, of course, they need to be able to be augmented to deal with the real-time AI agent issues that we'll be facing. Another profound issues I see with all this multimodal AI coming is the risk of automation bias, right? And I'm going to take it this way, not just automation bias, but also the clinical descaling of people. As these multimodal systems become reliably, incredibly performing exceptionally, there is a natural human tendency to defer to the AI machine. So instead of trying to do this things ourselves, we quickly want to just defer to the AI. If an AI is constantly analyzing EKGs, is constantly listening to the heart sounds, is constantly generating diagnosis and differential diagnosis, is constantly generating everything we need to do about the patients, junior physicians and medical students might lose the critical opportunity to develop their own clinical intuition and acumen. Because medicine is apprentice, it's honed through thousands of hours and observation and pattern recognition. If we outsource that pattern recognition, that season of learning to an AI, what happens when the power goes out? What happens when the system crashes? What happens when AI gets, anything can happen, right? Because of course, if humans will have accidents, AI may have lesser, but of course it does happen, all right? We are creating a generation of clinicians who are going to be highly proficient at managing AI systems, but lack the fundamental clinical skills of their predecessors. All right, so finally, here's how we're going to wrap it up. We must address the algorithmic bias. In this algorithmic bias, let's look at it this way. Multimodal AI systems are only as good as the data that they are trained on. All right, so currently you agree with me that electronic health records and health records in Africa and a lot of other countries are poor and are in silos. We don't have them put together. They're not even accessible. So therefore, we don't even have them to train AI on. So if the training lacks data diversity, the AI performance will suffer for marginalized groups. We have already seen pulse oximeters, basic pulse oximeters fail on darker skin tones. Now imagine a multimodal AI that misinterprets the visual signs of a rash on a black patient because it's a visual encoder. Its visual encoding that was done for the AI, right, was predominantly trained on white-skinned people. On an AI that hallucinates a medical history because it cannot accurately process the patient's regional accents or dialects. One thing I suffer even with humans, not talk of an AI that was trained on those. So if deployed without the rigors, without culturally inclusive validation, multimodal AI could exacerbate existing healthcare disparities rather than close them. So in conclusion, the arrival of real-time native multimodal AI is not just another iterative update in health tech. It is fundamental paradigm shift. It represents the transition of AI from what it was, from the passive tool we had it in the hands of people as just an AI scribe, to becoming an ambient participant in the healthcare ecosystem right through every single stage of patient management. The idea behind this is that the potential to eradicate administrative burnout, kind of elevate diagnostic accuracy, to democratize healthcare access, as well as ensure there's world-class access to everybody, wherever they are in the world, ensure you're getting the best medical expertise, and fundamentally restore that human interaction between care providers and the patient, and of course, within a close proximity, offer distance locally. We are going to open up ourselves to this AI. But most importantly, we must ensure we understand and have a grasp of this. But to realize this future, we must navigate the profound ethical, legal, and operational challenges with extreme caution. I'm going to say that again. In order for us to achieve all the benefit that multimodal AI offers us, we must ensure that we navigate the profound ethical, the legal, and the operational challenges with extreme caution and rigorous oversight. Technology is moving faster than regulation, no doubt about that. And it is up to you and I, the medical community people, to take the helm and ensure that these powerful systems are guided by the core tenet of medicine. First, do no harm. Right? Thank you for watching. If you found this deep dive valuable enough, please subscribe to the channel, leave a comment with your thoughts on how multimodal AI will impact your own specific field if you're not in medicine, and share this video with your colleagues. I will see you again in the next video. Bye.